Hi, everybody, and welcome. My name is Dr. Jason Goodchild, and the topic for tonight's webinar is going to be three key reasons to implement buffered local anesthesia in your practice. I am thrilled to be here, and I can't wait to share all this great information on buffering. So let's jump right in. Okay, so let's start with a picture that nobody has ever seen before, a needle with a smiling patient in the background. And the question is, what are our patients' biggest complaints about receiving local anesthesia? And we know that a lot of our patients, when they come to the office, they are well aware that they'll be receiving treatment that day, and their anxiety is focused on the local anesthetic injection. In fact, so many patients have said over the years, "Hey, doc, I'm fine after I get nice and numb." And so that's a hurdle for us. That's a big obstacle to getting started with treatment. And what are some of these complaints? Well, pain during injection, number one. I think this is the reason why we do all the little things we do around the time of local anesthetic injection. We apply topical, we wiggle the cheek, we may apply vibration as a counter stimulus, we could warm the anesthesia, we may try to distract the patient in other ways. But we're trying to make that experience better, make it easier for the patient to hopefully avoid that pain during injection. They also talk about a burning sensation immediately after injection. And we'll talk a little bit more about this as we go along. The idea that perhaps a low pH solution that we're injecting could have something to do with the burning sensation that patients feel. Then they also talk about lingering numbness, and that's just part of the equation, right? Wouldn't it be nice if we could inject local anesthesia and it would act for the time that we were going to be doing the treatment only and then be gone when we were done? And that's just not how it works. We know that the effects of the local anesthesia will wear off over time, but they do complain about the idea that that this persists for quite a long time after the procedure is done. A lot of patients complain about the feeling of not being numb enough. And I think that's a huge portion of it is not just the idea that they're fearful of the needle itself, but they're fearful of us beginning treatment before the area is completely anesthetized. And so they're worried about that first touch of the drill, that first touch of the elevator, to make sure that they will be numb enough and then numb enough throughout the procedure. They're talking about excessive needle discomfort, and that's really about after the procedure or after the injection is done. And then will that area be painful when the local anesthesia wears off? And will I have some residual symptoms or swelling at that site? So we keep in mind that this is a huge issue for our patients, the idea of anxiety and fear associated with that first part of the procedure. And as we as clinicians know that we have to get this part right. It has to be right in order to get the rest of the treatment going. We don't get to start all those great procedures we have planned until we get this part right. So how can we take our anesthesia to the next level? I mentioned some things that we a lot of us do, but I want to introduce for some of you, or for others, maybe it's a review, but talk about local anesthetic buffering. And if you didn't know, most of the local anesthetic solutions that we inject are pretty acidic, in the 3.5 to 4 pH range. And just to put that into perspective, I enjoy a Diet Coke every once in a while, and a Diet Coke is roughly pH 3.5. And now you can understand perhaps why that injecting a solution of 3.5 may actually cause some stinging or burning. So what is it? Let's define it. Let's define what is local anesthetic buffering. And so local anesthetic buffering involves adjusting the pH of the anesthetic solution using sodium bicarbonate. And I just mentioned that most of the local anesthetic solutions, and specifically the local anesthetic solutions that contain epinephrine, are going to be low pH, and that we can adjust that pH closer to body pH by adding sodium bicarbonate to help make the injection less painful and to improve the effectiveness of the anesthetic by increasing the amount of active neutral anesthetic that can penetrate nerve tissues. And so that's a bit of a mouthful. We'll take it and piece it apart during the next 60 minutes or so. So again, buffering local anesthetic involves adding sodium bicarbonate to neutralize the acidic solution. And roughly the ratio is going to be around 10 parts local anesthetic to 1 part sodium bicarbonate. So in other words, a 10 to 1 ratio is the recipe that you hear most often in the literature. It could be 9 to 1, 11 to 1. I mean, there's even 18 and 19 to 1, but most often it's around a 10 to 1 solution. And the reason we do this is because local anesthetics are acidic. And why are local anesthetics acidic? Well, we make them acidic for better shelf life, as well as the fact that epinephrine is soluble in water at low pH. So not only do we have to lower the pH of the solution to make sure that the local anesthetic itself is dissolved, but also we stabilize the epinephrine by doing that. So two reasons why most local anesthetics, specifically the ones that contain epinephrine, are prepared and sold as acidic solutions. Now I want to draw your attention to the bottom of the slide, and this is the basic chemical reaction that we talk about when we think of buffering local anesthetics. So that's sodium bicarbonate plus hydrochloric acid becomes salt, carbon dioxide, and water. And just so that you know, every buffering reaction will involve some CO2 gas. So if you see a little bubbling, a little effervescence in the cartridge after local anesthetic buffering, that's normal. And in fact, there's some good stuff associated with carbon dioxide that we'll get into a little bit later. So I mentioned that local anesthetics are prepared in an acidic pH, at an acidic pH. And so I did a study several years ago, and it was published in 2016 in Compendium, where I took a large sample of local anesthetic cartridges, basically all 7 solutions that are available in the United States, and I pH tested them. And what we found was that the average pH of the solutions that contain epinephrine, the average pH was 3.82. The average pH of the solutions that did not contain epinephrine was 6.34. And, that makes a lot of sense why those drugs seem to work very quickly. Additionally, those plain solutions tend to pinch or sting less because they're not as acidic. And so here are the 3 key benefits of buffering that we're going to talk about. The efficiency. The idea that a buffered local anesthetic will decrease the onset of anesthetic action. Patients will become numb faster. Reduced pain. Buffering local anesthetic will help cause less injection pain. And the last benefit, predictability. These patients will experience more effective and profound local anesthetic. So it will make it work faster, it will hurt less upon injection, and it will be more effective. Not only in profundity, but in length as well. It will cause increased duration of action. Quickly, let's review how local anesthetics work. I don't want to dive too deeply here, but just kind of give you an overview to help you understand the problem that we currently face with local anesthetics. And everybody who's ever injected local anesthetic knows it can take a while, it can sting a little bit, and it can be a little bit unpredictable. And why is that the case? Well, we also have to remember that local anesthetics exist in 2 forms. They always exist in 2 forms. A base form that is represented by the B, and then a charged form represented by the BH, which is the cationic form or the charged form, the ionized form, however we want to call it. Now, the charged form is the form that dominates in low pH, when the solution is low pH. So when we prepare these solutions to be shelf stable and we make them acidic, basically we push this stoichiometry towards the charged form. Now, as you can see, the charged form is also called ionized. It is the inactive form of the drug, and it's lipophobic. And the reason why it's inactive is because of it's lipophobic. It will not easily and readily cross the nerve membrane. As we change the pH to more of a neutral pH, we push the equation towards the base form. And as you can see, the base form is also called the uncharged form, the deionized form. It is the active form of the drug because it's lipophilic. The active form of the drug readily passes across the nerve membrane to get into the center of the nerve, the axon of the nerve, and will contribute to causing local anesthetic action. So just very, very briefly, the low pH form is inactive. As we change the pH of the local anesthetic solution, we drive it towards the base form and the active form that will cross the nerve membrane. Now, this is in the bottom left of the slide. It's just a picture that basically shows you what we all experience when we've ever tried to anesthetize an infected area or an infected site. If the area, the pH around this infected area is down, it's not 7.4 anymore. Now it's in the sixes. And as we said, in a low pH environment, local anesthetic becomes charged and it will not readily and easily pass across the nerve membrane, which is one of the reasons why in an infected area, a low pH environment, local anesthetic doesn't tend to work very well. In a high pH or a more neutral pH, again, that local anesthetic will then convert into its base form, its active form, and cross the nerve membrane. Now, to bring this home, we can actually calculate the amount of local anesthetic that's in these two forms, right? So it says that we'll just highlight lidocaine. Lidocaine, and it says that the percentage of its active form at pH 3.5. So this is the percentage of the local anesthetic lidocaine that is active in the cartridge that you pull out of the box, out of the wrapper, and you put into the syringe. Only 0.004% of the drug is active at pH of 3.5. If we raise the pH to closer to body pH, we get an increase in the active form of the drug to 24.1%. So it's almost like a 3-to-1 ratio when we buffer it. But when we don't buffer it, essentially 0.004 is active, but 99.996% of the drug is inactive at that low pH. And why is this important? Well, this accounts for why local anesthetics actually take some time to work. This accounts for the drug latency. Because if you didn't know, when we inject the base form at 3.5, when we inject local anesthetics in there right out of the cartridge at the low pH, like lidocaine as you see here, the body actually buffers it. So that what the body does is it takes this acidic drug, it converts it to its base form by raising the pH, and then it more readily passes across the nerve membrane. So as you can imagine, what we'd like to do is maybe have a buffered solution at the time of injection so that we can almost take the body out of the equation. The drug that we inject is in fact much more active and much more readily crosses the nerve membrane. So as I stated, the three key benefits of buffering are onset time. You get a quicker onset of action. And this is because if we inject a buffered solution, and we can take some of that body natural process out of the equation. Now, this is a bit of a complicated picture, but the very top of the picture is just what I said. This B plus a hydrogen ion goes back and forth with the charged form of the drug. And as I just mentioned with lidocaine, 0.004% is in the base form when it's at pH 3.5, and 99.996% is in the charged form or inactive form. And if we buffer it, we can make that ratio go towards more like a 3-to-1 ratio, and the base form then more readily crosses the nerve membrane. And that's not the end of the story because it's a bit more complicated. Once the active drug gets through the nerve membrane, it has to re-equilibrate, and then actually the charged form is the one that impacts the sodium-gated, voltage-gated channels to cause local anesthetic action and prevent sodium from flowing into the cell. So there's a lot going on here, but what we need to focus on is how do we get the drug into the nerve? And if we buffer it or we make it more active, it more readily passes across the nerve membrane. Now, one other little thing here to thoroughly confuse everybody is the carbon dioxide gas part of this equation. Now, I mentioned that every reaction involving buffering will generate carbon dioxide gas, which is a good thing. You may see a little bubbling or effervescence in the cartridge, but what carbon dioxide actually does is almost supercharge this reaction. because carbon dioxide will also readily pass across the nerve membrane. It also has direct depressant effect on the axon, concentrating local anesthetic in fat inside that nerve, and then hopefully, and also helping to convert it back to its active, its charged form that will be responsible for local anesthetic action. This is so-called ion trapping by Dr. Kachlov about 53 years ago. So we've known about some of this for a long time. And you ask yourself, well, if we've known about buffering and we understand the science and the potential benefits are that you could have quicker onset, it doesn't hurt during injection, and it works better, well, why haven't we done it more in dentistry? And my opinion on that is, why hasn't buffering caught on in dentistry to a large degree, is that we have standard armamentarium. We have the self-aspirating syringe, we've got cartridges or carpules, and then the dental needle. And anything that sort of disrupts that armamentarium makes it a little bit more difficult for us to implement. And so I believe that what we're looking for to really make buffering part of this equation for almost every single patient is an easy, fast, affordable way to do buffering. And I have some good news for you coming up. So like I said, local anesthetic solutions are prepared at low pH. Now, why aren't they already buffered? Why can't we just have buffered lidocaine right out of the box? Well, as I mentioned, it's for shelf stability. And if we raise the pH, what we could see is over time, if this was, right from the manufacturer and it came out of the box buffered, we could see things like precipitation or denaturing of the solution, or just it becoming inactive with no epinephrine. So it's not going to be stable out of the box. We have to do something chairside to actually buffer these local anesthetics. So this is an area of real interest for me. In fact, I've been looking at local anesthetic buffering for many years now, and I co-authored with Dr. Mark Donaldson a paper that was just published January 1st of this year, where we discussed these three key benefits. These three key benefits being quicker onset, reduced injection pain, and then I said more effective anesthesia, not just profundity, but length of anesthesia as well. So we can really make that local anesthetic work better for us. One thing I always get asked about this when I talk about the better, more effective anesthesia that buffering provides is the idea that does it change things? Does it change your max dosage? No. Does it change the half-life? No. It doesn't change the kinetics of the drug. In fact, buffering just makes the drug work better for you. So let's look at a little bit of literature. Not too much, just a little. I just want to hit a couple of high points, and then we'll move on to how to do it. Let's start off with a cover story from JADA, the Journal of the American Dental Association, from 2019, cover story. And the title of the article reads, "Do buffered local anesthetics provide more successful anesthesia than non-buffered solution in patients with pulpally involved teeth requiring dental therapy?" Now, these are hard teeth. These are hard areas to numb because if they're pulpally involved, there could be a low pH environment, which is a bit of a troublesome experience, if you've ever had to try and do this, meaning get good local anesthesia so you can access some of these infected areas. Well, the authors concluded that this investigation revealed that buffered local anesthetics are more effective than non-buffered local anesthetics when used for mandibular or maxillary anesthesia in pulpally involved teeth. Buffering of local anesthetics has a 2.29 times greater likelihood of achieving successful anesthesia. So it's not the magic bullet they're saying here, but they're giving you a better shot at doing it, right? Better chance of achieving that local anesthesia in those more difficult situations where there's a pulpal involvement. The next study I want to look at is by Dr. Stanley Malamud and Dr. Mick Falkel. It's a small study, but it's a good study, and they had 18 patients. They looked, their design was a crossover design, which means that one side got a buffered local anesthetic, and the other side, via inferior alveolar nerve block, got the non-buffered solution. So one side buffered, the other side non-buffered. And you could see that they did a remove and replace method, which is they took 0.18 mLs of the local anesthetic out of the cartridge, and they replaced it with 0.18 mLs of the sodium bicarb. Their final pH 1, and you can see that when you do remove and replace, you actually give a little bit less anesthetic, 36 milligrams for the non-buffered and 32.4 for the buffered local anesthetic. Their outcomes, the outcomes that they were looking for were injection pain and onset time. Now, the first thing was injection pain, and you can see based on their results that it says percentage of participants reporting 0 injection pain, and they used a 1 to 100 scale, point visual analog scale. Of the controlled anesthetic, which is the non-buffered, only 6%, 1 out of 18, said they felt no injection pain. Compare that to the buffered anesthetic, where 8 of 18, 44%, said they felt 0 pain upon injection, so much better. And the best part of this graph, this study, is the next slide, which actually shows the onset time. And the authors wrote, practitioners can expect that alkalizing cartridges of lidocaine and epinephrine immediately before delivering the anesthetic will hasten onset of analgesia and make it more likely that they will deliver a pain-free injection. On the left, this is the non-buffered. The mean time to anesthesia was 6.37 minutes. I'm sorry, 6 minutes and 37 seconds. And then on the buffered side, the mean time to anesthesia was 1 minute and 51 seconds. So about a 5-minute decrease in onset time, which sounds wonderful. Now, the next two studies are a little bigger, and they get into, like, for example, this next study is 70 patients, but they're ages 4 to 10. Some difficult folks to anesthetize. Two groups of 35 in this study, non-buffered versus buffered. They used articaine, so 4% articaine, 1 to 100,000 epinephrine, buffered again by move and replace. So they took out 0.18 mLs and replaced it with 0.18 mLs. It's a 9 to 1 because you do remove and replace. You take a little bit of local anesthetic out, 60.4 milligrams for the buffered local anesthetic. Each patient received a maxillary infiltration and a palatal infiltration for extraction of a primary molar. Outcomes, injection pain, onset of action, and efficacy anesthesia. Now, in the middle of the slide, you see the scale that they use to rate, for the patients to rate their pain. That's called the Wong-Baker Faces Scale. And it's numbers as well as pictures, so the patient can, immediately upon injection or whenever they need to query that patient, they can sort of point to the face that corresponds with the pain they're feeling. And this first part is pain on injection. Now, they did buccal and palatal, and you can see that the numbers, for the buccal infiltration, the pain score from 0 to 10, remember 0 is no pain, 10 is worst possible pain, was 3.71 for the unbuffered and 1.20 for the buffered, 4.62 unbuffered and 1.94 when we're talking palatal. But let me just tell you, I did some math here. When we look at the buccal infiltration from non-buffered to buffered, it was a 2.51 difference, meaning, if it was started out at 3.71, again, 1.2 was the buffered score. And the score was even greater or better for the palatal injection. We saw a decrease in pain score of 2.68 for the palatal injection. And on the right, you can see mean. Again, buffered did significantly better than non-buffered for the pain upon injection. Going on to the onset of anesthesia in the study, it's a little less, eye-opening. You could see that there's certainly onset was decreased when buffered was used. Again, from the subjective time to anesthesia, 77 seconds to 47 seconds, and then objectively 87 to 56. So statistically significant decrease in onset times for the buffered versus non-buffered. The part of this study that I really like, though, is the next one. So we saw decreases in pain, we saw quicker onset, but then they asked them pain during injection. And study versus control, there was a difference of 3.37, which was a significant change. Remember, the three benefits of buffering are onset time, right? Pain upon injection, and then making the local anesthetic work better for you. And this study clearly shows that you get better, more effective local anesthesia during buffering. The conclusion was less pain on injection, faster onset of anesthesia, and less pain during extraction were observed when buffered articaine was used for maxillary primary molar extraction. So a nice little study in some hard to numb individuals, hard to treat sometimes, that buffering did provide some significant benefit. Next study, even bigger, 100 patients ages 18 to 60. All patients required bilateral extraction mandibular molar, and they did 1.8 mLs of 2% Lita with 1 to 80,000 epi. It was diluted with 0.18 ml of sodium bicarbonate. So that was about a 10-to-1 ratio. And each patient received an inferior alveolar nerve block, and they had outcomes like injection pain, onset of action, depth of anesthesia, and duration of anesthesia. They also used a visual analog scale. In this case, it was 0 to 100, 0 no pain, 100 was worst pain ever. What was their conclusion? Well, this says this study concludes that the buffered solution has a faster onset of action than the non-buffered solution. The duration of post-op anesthesia was prolonged with buffering. Buffering also reduced pain scores during the early post-op period. I really like this study because this next graph kind of tells a nice story. It says table 4, comparison of duration of post-op analgesia in the two groups. And the way they defined this was nice. The duration of analgesia was calculated as the time elapsed between when surgery was completed and when the first analgesic drug was administered. For the non-buffered group, it was 129 minutes. For the buffered group, it was 327 minutes. So quite a big, almost a 200-minute additional analgesia when you actually buffered that local anesthetic. So again, key benefits of, hey, how can we make this local anesthetic work faster? Because we buffered it, the body doesn't need to do that for us. Perhaps the carbon dioxide and the fact that it's already in its active form, we make it hurt less. And because we can have that drug work better, we get better benefits like profundity and duration of action. Now, there's lots of other literature. I've just tried to cherry pick a little bit based on the time we have this evening. But is all the literature positive on buffering? Well, exactly. So I'm just going to show you two reels that aren't quite, again, a crossover design with an inferior alveolar nerve block. They were separated by 1 week, so the patient would come back 1 week later and get the other side nerve block. They used 3.6 mLs of non-buffered 2% lidocaine with 1 to 100,000 versus 3 liters, 2% lidocaine, 1 to 100,000, buffered with 0.6 mLs of sodium bicarbonate, which is a pretty high ratio. It's 5 to 1. Their final pH was 7.5. Their outcomes were injection pain and degree of pulpal anesthesia. So you could see that they gave 76 milligrams versus 60 milligrams. And what was their conclusion? It says buffering a 2% lidocaine with 1 to 100,000 epinephrine with sodium bicarbonate, as was formulated in the current study, did not statistically decrease the pain of injection, provide faster onset, or improve the profundity of anesthesia. So that's what they wrote. But in the article itself, they actually say this. It says, for non-buffered lidocaine, 72 milligrams of lidocaine was administered. And for buffered lidocaine, only 60 milligrams was administered. So that's a 17% less of the lidocaine itself. Even though less lidocaine was administered in the buffered formulation, the same anesthetic success rate was achieved as the unbuffered lidocaine. So it kind of shows you that even when less lidocaine is used, but it's buffered, you get the same results as if you had not buffered it. Right? So you almost supercharge that smaller amount of local anesthesia. One other quick one, because it brings home one other point I just want to highlight, which is, we can't over buffer. We have to follow the recipe. It's like 1 to 9, 1 to 10, 1 to 20, somewhere in there. But we really shouldn't be raising that pH above 7.5. In this case, they used undergraduate and graduate students. Again, a crossover design. One side got the buffered, one side got the non-buffered. In this case, they used 1.8 mLs of non-buffered 4% articaine with 1 to 200,000. It was 72 milligrams. And then, interestingly enough, they used 1.8 ml of 2% articaine with 1 to 200,000, buffered by remove and replace a 0.9 ml of sodium bicarbonate. So in reality, that was 18 milligrams. They only gave 18 milligrams in the buffered group. Target pH was 7.4. In fact, they went way too far. They went up to 8.14. Injection pain, onset time, and anesthetic success were their outcomes. And what did they say? They said that the buffered 2% articaine with 1 to 200,000 solution did not differ from non-buffered 4% articaine with 1 to 200,000 epinephrine regarding anesthesia success, safety, onset, duration of action, and injection pain. Buffered 2% articaine may be a clinical alternative to 4%, which is another whole great story to think about, perhaps less local anesthetic or less concentrated anesthetic. But like I told you, we really do not want to over buffer, because when we over buffer, what we get is potential hypertonicity, and that can cause local edema or tissue irritation. So if you choose to buffer, and again, I've been buffering for years. I can't speak, I tell everybody about, hey, we should be doing this. It's another way to make this experience better for our patients, but we have to follow the recipe. We want to make sure that we don't buffer above the normal body pH of 7.4, 7.5, somewhere around there. Okay. Should I buffer my local anesthetic? And if so, how do I do it? Well, the easy answer to should I is yes. I've only shown you a tiny little piece of the literature, but the literature is pretty much in agreement that you get those three potential benefits: quicker onset, less injection pain, and better effectiveness of the local anesthetic action. Well, how do I do it? Well, that's a bit more difficult. There are some existing ways to do it, and I'll just kind of give you the high level of them. There's a device called the Onset device by On Pharma. And in my belief, this device is elegant, but it's tedious and expensive. And I'll show you a little bit more about that. It was originally introduced in 2010. It's very cool. There's no doubt about that. But I'd like to make it easier and more affordable. There was a device called the Anutra local anesthetic delivery system. That's no longer available. Involved the idea of taking vials of lidocaine or local anesthetic and vials of the bicarb, and then this machine would sort of mix it for you, and you can pull it out using their syringes and needles. You can also by hand. You can just buy a vial of bicarb, draw out some bicarb, and then inject it into the local anesthetic cartridge. But there are some concerns. Although this could be the cheapest way to do it, there's some concerns about sterility and stability. So just a little bit more detail on the two current buffering options. Again, buffering, the science, helps to provide those three benefits. And how you do it, it could be personal choice, it could be cost concern. There are lots of reasons why you may pick one or the other. I just want to highlight what currently is available. Well, when hand buffering, we're using little syringes, little 1 cc tuberculin syringes. We may remove some local anesthetic. We may replace it with bicarb. But we're using the needle multiple times. Also, bicarbonate is not stable after that vial is punctured. It off-gases very quickly. And because there's no bacteriostat or preservative in those vials of bicarb, each time you're introducing a needle, could you also be introducing bacteria? There's another concern that actually I would really like to look into further. It's the idea of coring. If you puncture that rubber diaphragm of the sodium bicarbonate vial over and over and over again, are you pushing little pieces of plastic inside of it? Cost, well, the last time I bought a vial of bicarb, it was $25. And I calculated that if I just used 0.1 mLs of bicarb, that could be 500 doses in a vial of bicarb. That's the good news. Bad news is they don't last that long. You'll never get that many out. In fact, you'd probably be throwing a lot of that vial away because of what I'm going to tell you in the next two slides. The on-pharma system, like I said, elegant, but to me, not intuitive. It involves multiple steps, and it is kind of expensive, as you can see there. I did the math, and it worked out to be around $5.80 per buffer. If you wanted a chairside buffer, again, like I said, probably the cheapest way to do it, but also comes with stability and sterility concerns. These are the three things you'd need. Some insulin syringes graduated at 1/10 of a millimeter increments, a vial of bicarbonate, 8.4%, and then your normal armamentarium of a carpule and a self-aspirating syringe. And I did this study. So what I wanted to do is, and I published this in 2019, is I wanted to compare the recipes. I wanted to compare the idea of, hey, if I remove and replace either by the onset device or by hand, can I kind of reach the same pH? And I compared the 9:1 ratio. I compared a 19:1 ratio, which is 0.09 mLs, half of the bicarb that I took some out and put some back in. And then the last one was I just had an idea. I had an idea that instead of removing some of the local anesthetic and replacing with bicarb, couldn't I just inject some bicarb into the local anesthetic? And instead of a remove and replace, I called this the direct injection technique, which is, again, I didn't take anything out. I just put some bicarb in the local anesthetic cartridge. There's a little bit of extra headspace, and I wanted to see if I could just put 0.1 mLs of sodium bicarbonate into the local anesthetic cartridge, and would it work? Well, my conclusion was, after testing all three of these ratios with all 7 solutions of local anesthetic currently available in the United States, was that it all was the same. It all basically was the same. They all got to 7 or slightly above because our target pH should be between 7 and 7.4. And by the way, we can buffer every local anesthetic solution. I mean, we get the best bang for our buck out of the ones that contain epinephrine, but all local anesthetics can be buffered. Certainly, whichever method you choose, we should be able to use any local anesthetic solution. So again, I just wanted to investigate whether I could just inject some sodium bicarbonate in, and would that also work? And so just a graphic, a picture of showing you what I did. So there's 9:1, 19:1, and 18:1. On the far left, I took out 0.18 mLs and replaced 0.18 mLs of sodium bicarbonate. And then I did half, 0.09, remove 0.09, and then replace it with 0.09 of bicarb. And then my study was really around, hey, what if I just injected some bicarb in? And that was 0.1 mLs. And what I was able to show was that they were all the same. They were basically all the same. And so the reason why I like the idea of direct injection is because it's fewer manipulations with a needle. It's easier to do. But I also mentioned that the direct injection, or the hand buffering technique, rather, does come with some concerns. When you're dealing with a vial of bicarb, again, you have to know that these vials of bicarb do not contain any bacteriostat. They are single dose vials. They are not meant to be stored. They are not meant to be reused, putting a different needle in every single time. Again, I mentioned the idea of coring, but I'm concerned about the off-gassing of CO2, which means it won't be stable. It may not work very well over time. And then, of course, because there's no bacteriostat, am I introducing bacteria in every single time? So I looked at the National Association of Pharmacy Regulatory Authorities standards for pharmacy compounding, because I really wanted to see, if this is a single dose vial, how long can I keep it in the office? How many times can I use it? I mean, it says single dose, but geez, that's a lot of liquid. I'm just going to throw it away, or how long can I use it? And according to the standards for a single dose vial, it says if the vial is punctured in a primary engineering control that maintains ISO class 5 air quality, the beyond use date is 6 hours. So that would be under a hood. So if you're accessing this vial under a hood, the beyond use date is 6 hours. It says 6 hours after an initial needle puncture, the vial can no longer be used. Once the vial is removed from the hood, it must be discarded. If the vial or, this is the very bottom of the slide with the arrow, if the vial or another single dose container is opened or punctured in an environment with air quality worse than ISO class 5, meaning not under a hood, the beyond use date is 1 hour, which now, geez, I mean, I just bought this whole vial. It's got 500 potential doses in it. I can't use 500 potential doses in 6 hours or in 1 hour or even 6 hours. So I'm going to be ending up throwing a lot of this away. And I've heard some other authors, other speakers talk about, man, we should refrigerate this, but refrigerate this vial to prolong its, its shelf life. But we just don't have any good data about how long that will be. And so that's my biggest concern with chairside hand buffering, is that vial of bicarb is really not going to last very long. Now, this is just this blue call out is just a little more information. It says ISO 5 clean rooms are required to have 300 to 480 air changes per hour of HEPA filtered air, or less than 29 particles per cubic meter, less than 5 microns. By comparison, a conditioned office space like a dental office would have more than 10,000 as many particles per meter. So again, not a great environment to be able to do this, to hopefully prolong the use of this vial. If this vial was a multi-dose vial, it's not, unfortunately, it's a single dose vial, the beyond use date would be 28 days, but it isn't. It isn't. So again, that's my major concern with chairside buffering. Are you excited to start buffering? Yes, but geez, it doesn't sound like we have the solution yet. We have the on-pharma device, right? It's elegant, it's kind of tedious, and it might be a little expensive. Hand buffering, we use the multiple manipulations with a needle, but we have some concerns about the vial of bicarb. So what should I do? If I'm thinking pie in the sky, we just need to find a buffering method that works for us, because the science of buffering is there. I mean, it really does support those 3 benefits of quicker onset time, reduced injection pain, and more effective anesthesia. It's a hot topic, and some new solutions are coming. And what features should we consider? Well, we want it to be single use. I mean, wouldn't that be nice if every single time you wanted to buffer, you had a single use way to do it that was always sterile, it was always shelf stable, and it was easy to use, meaning no mixing, minimal parts and pieces, no manipulations with a needle? Of course, it has to be compatible with all local anesthetic solutions, and because everybody is very cost conscious, we need to make it affordable. And then my research, remember when I said direct injection, meaning I don't want to take any local anesthetic out, decrease the amount of local anesthetic that I have on board, but can I just buffer what I have? And that's where the direct injection technique, or adding a small amount, and my research was it 0.1 mLs of bicarbonate. Can you just add that in, and will it do the job? So that's what I'm really looking for. Now, great news, breaking news for you guys. The solution is here. The press release came out in October of 2024 that Premier had developed a sodium bicarbonate delivery system, and that Premier was partnering with Septidon to sell it. And we developed this small little capsule that contains 0.1 mLs of sodium bicarbonate. So this was the press release back in October. Again, this was teasing the idea of a new sodium bicarbonate delivery system to buffer local anesthetic cartridges, and it was going to be called Buffer Pro. And it was going to deliver 0.1 mLs of sodium bicarbonate via the direct injection technique that I just showed you. And how was that going to work? Well, it was these little capsules that all you needed to do was push the capsule, push them together essentially to deliver the 0.1 mLs into the local anesthetic cartridge. You did not need to remove anything. So you still were able to deliver the same amount of local anesthetic, just adding that 0.1 mLs. Even better news, it was just released. Just a few days ago, on February 3rd, it was officially launched, Buffer Pro. Again, a sodium bicarbonate delivery system so that you can realize all those benefits of buffering. You can get the science that we keep talking about, the quicker onset, the less injection pain, and making the drug work better for you. And as you can see, those little caps, just push that together with your dental cartridge, and then it will deliver the 0.1 mLs. And here's a better look at it. You can see the very top of the capsule contains the 0.1 mLs of sodium bicarbonate. And again, it's all protected, meaning there's no possible way to get a needle stick. It just involves one motion to push those two things together. And like I said, here it is. Here's the directions for use right out of the IFU. It says, number one, remove the capsule from the sterile foil. Each capsule of Buffer Pro comes sterile in its own foil package. You could just have, 5 or 10 of these in your little lab coat pocket and then pull them out every single time you need to use them. There's no concerns of sterility or stability. Each one is individually packaged, sterile. And then number two, insert the open end of the Buffer Pro capsule into the septum end of the local anesthetic cartridge and push until it stops. That's it. Right? You remove it from the capsule, it's ready to go, essentially. One motion, easy to buffer your local anesthetics. Now, it does come with a 2-year shelf life, and part of the magic of this system is that it's individually packaged and sterile. In fact, the way that this thing is packaged is that it increases, meaning how do I say this? It is optimized to maintain that shelf life over a 2-year period. So the magic is not just in the capsule, and that it's actually in the packaging too. So when we made this, we wanted to make sure that it was going to be sterile and stable, so that when you pull it out and you're ready to use it, it's ready to go. Now, I would love to see people buffer every local anesthetic injection. I live in the same world as you guys. Maybe you save this for your hard to numb patients or your infected teeth. And of course, it'll work for all injections and all local anesthetic solutions. But we tried also to make the price point affordable. It will be $3.60 per capsule. So it will be easy, like I said, sterile, shelf stable, and then affordable as well. So as I wrap up, I have a very short video just to kind of show you how easy it really is. And like I said, all you really need is your cartridge, whichever cartridge you want. It could be articaine or lidocaine or any kind of solution that you choose. And then you pick one capsule in its foil package, and let me show you how to do it. And that's it. Voila, buffered. Now, the IFU does say to maybe invert the cartridge a couple of times, but that may not even be needed. It's as soon as you take the capsule off, it is ready to go. Put it in the syringe, and it's ready to be injected. Now, one of the last little bit, this is my very last slide, but let me just tell you that the best way to use Buffer Pro is use that cartridge immediately. Use it chairside, rip open the caps, the foil package, buffer your cartridge, put it in the syringe, and inject the solution. So we don't store buffered cartridges, we use them right away. But hopefully that gives you a good indication of just how easy it is to use Buffer Pro, so you get those benefits of quicker onset, less injection pain, and just better overall local anesthesia. So with that brings us to the end, and it does leave a little bit of time for questions. And so if there are questions, I'll try to look in the Q&A and see if I can answer a few. Okay, Q&A. Can you buffer marcaine the same as lidocaine? And the answer is absolutely. You can buffer any local anesthetic you want. The solution, the Buffer Pro local anesthetic sodium bicarbonate delivery system that I just showed you, can be used for any local anesthetic solution. Next one. Does warming the anesthesia denature or make it ineffective as it is too hot? Now, the interesting thing about the literature around buffering local anesthesia is that the temperature is somewhere between 38 and 42 degrees C. And it has been shown that warming local anesthetic does provide a benefit. In fact, I don't think you can warm it. So the best way to warm local anesthesia, I think, is to take the warmest water out of your tap and put it into a small little cup and then put the cartridge in the water for a few minutes to warm it up. I imagine that, again, the question says, does warming the anesthesia denature it? I imagine there is a temperature where it will denature it, but as long as we're trying to get to the target temperature of 38 to 42 degrees C, or just warm water out of your tap, that will not be a problem. In fact, the temperature that those cartridges can withstand easily is up to 70 degrees C, which is higher than you'll get out of the tap. So tap water, warm it in your hand, that sort of thing. It should not denature that local anesthetic or degrade it. Can you use a buffered anesthetic for intraosseous? Yes, you can use buffered anesthetic. Again, you're not changing the local anesthesia in any way. You're not changing the kinetics of it. Its half-life, it's that kind of thing. Its max doses or it's just making the local anesthesia work better for you. When you think about interosseous anesthesia, you probably think about the volume as an important factor. And so maybe because you have such small volumes in those areas, make those small volumes work even better for you. So the answer to the question is yes, you can buffer intraosseous anesthesia. There's no reason you can't buffer any solution for any injection. So question talks about the 18-to-1 ratio. The truth is that there's been many ratios studied in local anesthetic buffering. In fact, if you look on the medical side, you'll see 1 to 10, 1 to 20, and so forth. The ratios that go the opposite way, meaning you use less bicarbonate, they're really not a concern. The concern is the opposite way, which is you potentially over buffer. And I mentioned that one study that looked at a pH over 8.8, and it was like 8.14, and you saw potential tissue irritation and edema. So I have no problem fully recommending an 18-to-1 or even a 1 to 20 ratio, because what you want to end up with is a pH sort of in that target zone. Because 7 to 7 is going to be $3.60 per capsule. And again, let me just mention one other thing. There's a question around 18-to-1. When you think about the buffering reaction, all of the low sodium bicarbonate is used up on that reaction. So the resultant pH is really the most important factor. And so we think about the injected pH, that's what we're shooting for. How did we get there? We got there by remove and replace or direct injection. What did I actually do if I was going to buffer my local anesthetic before this? I was hand buffering. And I can tell you that I always had concerns around buying a big vial and throwing away a lot. So there are smaller vials. I think there's a 10 ml vial. They're a little harder to get, but I was hand buffering. And I was refrigerating, and I can tell you that I always worried about stability and sterility. Again, cost of Buffer Pro is $3.60 per capsule. Yes, is that $3 per cartridge? Yes, it would be $3 per patient. So if I use one cartridge for every patient, it would be $3.60 per patient per cartridge. Is it safe to buffer for an infraocular nerve block? Of course it is. Like I said, you can buffer any cartridge, any local anesthetic solution for any injection. There's not a type of injection you couldn't use a buffered solution with. Any contraindications to high blood pressure? Well, of course not. We're not giving any more local anesthetic, and we're not giving any more epinephrine, so all the same rules apply. So again, we're just making the local anesthetic work better for us. There's no contraindications to patients with hypertension or high blood pressure. So this one, the doctor says, we hand buffered for a while, then we stopped. We had a few cases of prolonged anesthesia and also a few of trismus. Now, trismus is puncturing a muscle. It shouldn't have anything to do with buffering per se. Could that be due to improper buffering? Too much, too little? Any thoughts on that? Well, I'd need to know the ratio. Certainly, if the ratio is too high, that could be cause tissue irritation. But again, trismus is a possible complaint for any local anesthetic injection that passes through a muscle. Again, 360 per cartridge. Will it prolong the effects of carbocaine? Uh, um, I haven't seen a study that looked at buffering carbocaine specifically, but I can tell you that it will make your carbocaine work better. Now, carbocaine is already pretty basic, above 6 pH out of the cartridge, but you could certainly buffer it and get a little bit better benefit. One study I can remember about carbocaine is they looked at, instead of warming carbocaine, they looked at cooling carbocaine. And when they cooled carbocaine, they actually showed an increase in the duration of action of carbocaine, which is a weird study. But I don't know why anybody would want to cool it, but they did. Any patient contraindications? Nope. Buffering is just making what you're already doing work better for you. Provide those 3 benefits of less injection pain, quicker onset, and better effectiveness overall. And as soon as you buffer it, you do need to use. So the question is, how soon after you buffer do you have to use it? I would use it right away. Like I said, rip open that foil package, buffer, and use immediately. Is buffering done by medical professionals? In fact, yes. Most of the literature initially was on the medical side, and we've certainly seen a lot of dental literature in recent on the medical side, because they're using vials of local anesthetic and vials of bicarb. They don't really have a standard armamentarium. That's one of the reasons why I believe it was probably much more popular on the medical side before the dental side. Is buffering needed for plain local anesthetic? The answer is not really, but you could. The biggest benefit is certainly the idea that the lower pH, meaning the ones that contain epinephrine, you get the best bang for your buck when you buffer those. But you can buffer anything. You really could. I mean, the same rules apply. You're taking a pH that's, less than 7 to 7.4, raising the pH, making more of it active, more of the base form, and then getting those benefits we keep talking about. Can I buffer prior to topical? Will leaving it on a tray for 2 minutes have an effect? I'm not quite sure what that means. I'm a little confused. If you want to, I'm not understanding that question. So is there any adverse risk of buffering and having that buffer and or anesthetic gel get into the blood vessel? No, there should not be. Remember what we're talking about here. We're not changing the drug itself. So any risk that you had or any concern you had for an intravascular injection is the same whether you buffered it or not. I didn't change the local. I didn't change the amount of epinephrine. All I did was make it more active right out of the cartridge. So instead of you injecting it in the body, buffering it, you just buffered it in the cartridge outside the body. So again, all the same rules apply for all the things we're doing. We're just making the drug work better for us. Doesn't change the max dose, doesn't change the amount that could potentially get into any vessels or cause any adverse reactions. It's just you out of the cartridge. Any known adverse reactions, allergy to buffering? No, I'm not aware of any allergy concerns with buffering. Adverse reactions, I went through the biggest and probably the only one that I'm aware of, which is, you have to follow the recipe, whether it's 1 to 9, 1 to 10, 1 to 20, 1 to 18. You just have to use the right recipe to reach the target pH. We want to get somewhere in the 7.4 range, and we don't want to exceed that or raise it, make it more basic, because again, I mentioned the idea of local tissue irritation or edema. Good question. It says, how does 20% topical benzocaine this process? Not at all. Just use your regular 20% benzocaine that really does not much of anything. If you look at the studies around benzocaine topical, there's so many factors involved with it: drying the tissue, contact time. And then, of course, there's actually studies looking at where you use the topical in the mouth. If you use 20% topical for an inferior alveolar nerve block, studies show it really does nothing. The best benefit for a 20% benzocaine is maybe anterior maxilla, buccal anterior maxilla. Again, not very effective on palatal. Is it more of a placebo for our patients or sort of a psychosomatic thing? But it should not, however you choose to use topical, it will not affect buffering in any way. Good question. It says, does buffering allow for local anesthesia, local infiltration of lower teeth to be as effective as inferior nerve block? Um, there have been some studies looking at these kinds of things. I don't think I've seen a study that says that you could just take buffered lidocaine and inject it, buccal to a lower first molar and it'll work just as well as an inferior nerve block. I haven't seen that. I've seen some studies with articaine and buccal infiltration, but again, I don't think we have that. Will the buffered local anesthesia like buffered lidocaine work on lower infiltrations? Again, I don't think we have that one yet. I still think that you do what you normally do when you have a greater chance of success, a better patient experience, a more numb patient. And when we have a more numb patient, we have happier providers because I'm not worried anymore. These patients are just nice and numb, and we can do what we plan to do. Again, I'm not sure I understand the question per se. It says, how much is the amount of anesthesia for children who suffer from a chronic disease such as diabetes? I don't know if diabetes, kids, of course, we're always worried about the amount because we reach max doses very quickly. I believe there was an article by Dan Becker from a while ago, and he talked about maybe Paul Moore. They talk about something called the rule of 25, which is one cartridge of anything for every 25 pounds of body weight. And I always remember that when it comes to kids, because the idea if I've got a 50-pound kid, then I've got two cartridges of anything, one of Lito, one of articaine, and I'll always be under the max. So that's just how I remember max doses for kids, the rule of 25. Um, Great question, and I know we're getting close to the end of time, but there's a few more. I'll try to power through them. It says, what needle size do you prefer to aid in lower pain on injection? Well, there's a lot of good literature around needle size and pain. Most I can give you the sort of the summary. 25 and 27 gauge needles, they hurt about the same. 30 may be a little bit different. That may be a little less painful depending on which literature you read. But we never recommend using a 30 gauge needle for a lower block because of the chance of separation and of course needle deflection. So what do I use? I'm just using, most of the time I'm using 27 gauge needles, unless I'm doing sort of local infiltrations on the maxilla or palatal. I'll use a 30, but I'm using 27 most of the time. Seems like the ideal use for buffering would be an emergency patient with severe pain, making Marcaine work faster and longer. Now, Marcaine, you're right, Marcaine is an interesting local anesthetic because it doesn't work very fast. And to get the true benefit of Marcaine, you need to block it, use it as a block. If you infiltrate Marcaine in the maxilla, it's no better than lidocaine or articaine. So you must use it as a block to get the true benefit of Marcaine. But if we're going to buffer it, I don't think I've seen a study on buffered Marcaine and onset of action. But just the science of it would mean that Marcaine potentially could work faster. Quick question. How long is a buffered vial good for, like a buffered cartridge? I think that the right answer is you use them immediately. You buffer the cartridge and you use it. You don't store it. So it's not like I count up the number of cartridges I'll use in the day. I'll buffer them up all in the morning and use them. I wouldn't do that. I would just buffer chairside right before you're ready to give. Right before. It's certainly not a day and certainly not a week. It would be right before use, right before use. Part of my study from 2016 looked at storing of buffered local anesthetic solutions. And what we found was that the pH continued to rise over time and epinephrine concentration went to zero very quickly. So we use buffered local anesthetics immediately upon buffering. Can you use sodium bicarbonate anesthetic solution? Absolutely. You can use it with any solution. You just get the better bang for your buck out of the ones that contain a vasoconstrictor. Do you buffer? Do you need a topical first? If you use topical, I just use topical. Try injecting patients without using a topical. They're going to be like, whoa, doc, where's that gel you usually put on me, right? So do what you normally do, just buffer to make the local anesthetic that much better. Is there a time limit for how long after you buffer that you can use it? Not really, but the general rule is immediately after buffering, use it. It's the best bang for your buck. All right. So that's all of our time. I'm getting played off with the music from Viva. I hope everybody enjoyed it. My email is there. If I didn't get to your question, please email me. I'm happy to answer any questions you guys have. And I'm really happy that we were able to discuss this tonight. Thank you for your time, and we'll see you next time.